Today we'll be talking about the treatment of high blood pressure. I think in the last lecture we discussed about pathophysiology, definition, grading, staging of the hypertension, and how to investigate the hypertension. In this lecture, we'll basically focus on how to treat the patients with hypertension. So before starting patient on the treatment for the hypertension, you should stratify the patients according to their BP measurement. As shown in this chart, where if the patient has the blood pressure of less than 120 by 80 millimeters of mercury, then that is normal blood pressure. Those patients should be advised for optimal lifestyle habits, and this should be assessed every 1 year for the increase in the blood pressure. However, if the patient has elevated blood pressure, that is systolic blood pressure between 120 to 129, with the diastolic BP less than 80, then we should ask the patient to follow non-pharmacological therapy for controlling the hypertension, rather than starting them on the pharmacological therapy. Those patients should be assessed every 3 to 6 months for the blood pressure. Non-pharmacological therapy we'll discuss about that in the after some slides. So if the patient has a stage 1 hypertension, that is if the BP is between 130 to 139 systolic blood pressure and the diastolic blood pressure between 80 to 89, then we should decide whether we should start or not start the pharmacological therapy, because these are the borderline patients. If these patients have the atherosclerotic cardiovascular disease risk or the cardiovascular disease risk more than 10% chances of having the cardiovascular disease risk, which can be calculated by using various risk calculators. If the risk is more than 10%, then we can start the patient on BP lowering medications, and as well as counsel them about the non-pharmacological treatment of the hypertension. However, suppose if the patient is young, there are no other cardiovascular risk factors, is a non-smoker, and the cardiovascular risk comes to be less than 10%, then we should ask only them for the non-pharmacological therapies like salt reduction, physical activity, use of potassium-rich diet, and we should reassess the patient. And if the patient falls in the stage 2 hypertension based on our clinic or the home BP monitoring, then we should start them on the pharmacological therapy as well as advise them for the non-pharmacological therapy. So after starting the patient on the BP medications, we should assess the patient every 1 month to see whether the drugs we have started or the pharmacological, non-pharmacological therapy we have started had a proper BP controlling effect or not. If BP goal is not met, then we need to escalate the therapy, and we should ask the patient about the compliance and adherence to the therapy. And if the BP goal has been met, then we should again follow up the patient in every 3 to 6 months and assess them regularly. So we need to understand these things before starting the antihypertensive therapy in a newly diagnosed hypertension patients. So now we'll be discussing about the non-pharmacological therapies. The non-pharmacological therapies basically include the lifestyle modification as well as the dietary modification. So one of the important aspect of the non-pharmacological therapy is weight loss. If a patient can lose some weight, then his or blood pressure will decrease. So it is said that almost about 1 kg of the weight reduction will decrease the blood pressure by 1 millimeters of the mercury. So if a hypertensive patient loses his weight to some extent, then he can decrease the blood pressure by 5 millimeters of the mercury. Similarly, a healthy dietary pattern can decrease the blood pressure in the hypertensive patient by up to 11 millimeters of mercury. So the healthy diet means that patient should consume the diet which is rich in fruits, vegetables, whole grains, and the diet which has a low-fat dairy products, as well as the reduced content of the saturated or trans fat. Patient can increase the diet containing polyunsaturated fatty acid or monounsaturated fatty acids. So this type of the diet, which is also known as the DASH diet, and there is also next type of the diet which is commonly prevalent in the European nations, which is called as a Mediterranean diet. That Mediterranean diet is also useful in decreasing the blood pressure in the hypertensive patients. So next aspect is the reduction of the daily intake of the sodium. So if patient can cut off the intake of the sodium to less than 1500 milligram per day, then they can decrease their blood pressure by 5 to 6 millimeters of the mercury. So it has a very important effect on reducing the blood pressure. So every patient with the hypertension should be counseled about their dietary pattern, modification of the salt intake for the weight loss, as well as they should be encouraged to take the diet which is rich in the potassium, because potassium daily intake of the about 3,500 to 5,000 milligrams per day of potassium will can decrease the blood pressure by 4 to 5 millimeters of the mercury. So these are the changes which patient can start when they get the diagnosis of the hypertension, to reduce their drug dose, as well as their they get the extra benefit. There are also some other non-pharmacological therapy like physical activity. If the patient can get involved in the aerobic exercise like 90 to 150 minute brisk walking per week, or the dynamic resistance training or the isometric exercises for some duration throughout the week, then they can decrease their blood pressure by about 5 millimeters of the mercury. Similarly, if the patient consumes alcohol in the larger amount, then we should ask them to moderate their alcohol consumption. So, according to the various guidelines, men can drink less than 2 drinks daily, and women they should drink less than 1 drink daily. So, if they can cut off their alcohol intake, and if they get involved in the increased physical activity, then they can get the added benefits in addition to the pharmacological therapy they are taking. Or if any patient has the borderline blood pressure, then when you are in doubt whether to start or not to start the treatment, and when the patient is reluctant to start the treatment, you can keep the patient on the pharmacological therapy, counsel them about the possible complications, and ask them to follow this non-pharmacological therapy. And it may to some extent delay the initiation of the antihypertensive therapy. So this non-pharmacological therapy has important role in the management of the hypertension. So after understanding these non-pharmacological therapies, now let's move to the antihypertensive drugs, which we can be used in the management of the hypertension. There are various groups of the drugs which can be used, and they are basically divided into first line agents and the second line agents. So first of all, we'll talk about the first line agents, and then we'll talk about the second line agents. So every patient should be, if we are starting on the pharmacological therapy, they should be started on the first line therapy. And if the dose should be gradually titrated according to the response of the patient, and also we should weigh the complications or the side effects of the drugs. So in that way, we can titrate the first line therapy. And if the first line therapies are not being able to control the blood pressure properly, then in some patients we might need to add on the second line therapy. So that is how we approach the hypertension patients. So now let's talk about some antihypertensive drugs. So there are various classes of the drugs which can be used as the first line treatment for the hypertension. However, there are only three or four major groups of the drugs which are usually considered the first line agents. The first is the use of the thiazide or thiazide types of diuretics. These are a type of the diuretic drugs which have added the antihypertensive effect. So they are the first line agents. So some of the examples include chlorthalidone, hydrochlorothiazide, thiazide, indapamide, and metolazone. So this can be given in the OD doses. However, these drugs has some adverse effects, like they can cause hyperglycemia, hyperlipidemia, as well as hyperuricemia, and they can also alter the electrolyte levels, like they can cause hyponatremia, hypokalemia. They can increase uric acid level and the calcium level. So these drugs should be cautiously used in the patients. So you should consider other relevant comorbidities before starting patient on this group of the drugs. And the next group of the first line therapy is ACE inhibitors. So these drugs include drugs like enalapril, lisinopril, ramipril, as well as captopril. So these drugs, they usually inhibit the angiotensin converting enzymes, and they have adverse effects, like they can increase the potassium level in the CKD patients, as well as this should be used cautiously in patients with the renal artery stenosis. And these drugs should be strictly avoided in the pregnancy due to their teratogenic effects, and this should not be combined with the angiotensin receptor blockers or other drugs which act on the renin-angiotensin system. Similarly, next group of the drug which can be used as a first-line agent in the treatment of the hypertension include the angiotensin receptor blockers, which are also known as ARBs. They include candesartan, irbesartan, losartan, olmesartan, telmisartan, valsartan. These drugs are available in the market, and you will prescribe these drugs to the patient when you come to the internship years later on. So you need to know about all these categories of the drug. So angiotensin receptor blockers and ACE inhibitors are have got similar type of the safety profile. ARBs also can cause hyperkalemia, and they should be used cautiously in patients with the renal artery stenosis, and they should not be combined with the ACE inhibitors. So these are the three first line agents which can be used in the patients with hypertension. There is also other first line agents like calcium channel blockers, basically non-dihydropyridine calcium channel blockers like amlodipine, nicardipine, and nifedipine. These are the calcium channel blockers, but they are dihydropyridines. This can be used as a first line agents. However, these drugs should be avoided in patients with heart failure with reduced ejection fraction, and they can cause the pedal edema, so it should be used cautiously in patients who complain of these side effects while using these drugs. Similarly, there are some non-dihydropyridine calcium channel blockers like diltiazem and verapamil, which can be used as a first line agents, but this should be used cautiously while using them with the beta blockers, because they can cause bradycardia and the heart block. As well as these drugs, as they decrease the contraction of the heart, so they should not be used in patients with heart failure with reduced ejection fraction. And these are the first line agents: calcium channel blockers, ACE inhibitors, ARVs, and the thiazide diuretics. These are the categories of the first line agents for the hypertension. You can start a new patient with hypertension with any of these drugs, but we should also decide which drug to use based on the other comorbidities like presence of hypertension, presence of diabetes, heart failure, renal impairment, as well as pregnancy. We have to consider all those things before choosing one antihypertensive agent. So if you cannot control the blood pressure of a patient using the first line agents or the combination of the first line agents, then we may have to start the patient on the secondary agents or the second line agents. These include the loop diuretics like furosemide, torsemide, bumetanide. These are usually the add-on drugs in the patients with CKD or in the patients with the heart failure with congestion. And similarly, if the patient has other comorbidities like hypokalemia, and then we can use the potassium sparing diuretics in addition to the primary first line agents for the treatment of the hypertension. So you should know the name of these and the group of these drugs for your exam purpose also, because this is frequently asked question in the various exams. So in the diuretic, you can also use the aldosterone antagonists like eplerenone and the spironolactone. These are basically used in the patient with the resistant hypertension. So when first line agents are not working properly and the patient has resistant hypertension, then we usually prefer the use of these aldosterone antagonists. So these drugs also can cause hyperkalemia, so this should be used cautiously in patients with renal dysfunction. As well as one important adverse effect is the gynecomastia, which is usually caused by spironolactone. If spironolactone causes gynecomastia, we should switch patient from the spironolactone to the eplerenone, or we can use other potassium sparing diuretics like amiloride. Okay, and similarly, next group of the second line agent is the beta blockers. So beta blockers can be divided into various categories like cardioselective, non-cardioselective, cardioselective with vasodilatory properties, with intrinsic sympathetic activity, with alpha activities. So basically, they are not the first line agents in cases of the newly diagnosed hypertension, but we should consider adding beta blockers to the hypertensive patient if they have coexisting heart failure, or they have ischemic heart disease, or some patients who need peripheral vasodilatations like peripheral arterial disease. In those cases, we can use nebivolol, as well as in the heart failure patients, we can use bisoprolol, carvedilol, or metoprolol, as well as in some patients with hypertension with coexisting hyperthyroidism, we can use drugs like propranolol. So choice of the beta blocker as an antihypertensive agent depends upon the comorbidities of the patient, and if the patient is not being able to achieve the target blood pressure goal with the first line agent, then only we use the beta blockers in the second line. So you should always know this. You should know which are the first line agents and which are the second line agents, and what are the comorbidities which will decide the choice of which antihypertensive. So you need to know these categories of the hypertension antihypertensive agents. Similarly, you can use other drugs. There are some other groups of the drugs which are useful when these primary and the other secondary drugs are not useful, like direct renin inhibitors like aldosterone can be used. Similarly, alpha blockers like prazosin, doxazosine, terazosin can be used, but these can cause the severe postural hypotension or orthostatic hypotension, so they should be used cautiously. However, they are the first line or the important drugs to control the prostatic hyperplasia. So you can, in those comorbidities, you can use this drug. Similarly, you can use the centrally acting drugs like alpha-1 agonists and other centrally acting drugs. However, these are the last choice of the drugs when other drugs are not able to control the hypertension. They include drugs like clonidine, methyl-dopa, and guanfacine, as well as you can use some drugs like hydralazine and minoxidil. But they are used only in the some relevant cases with some special comorbidities. At least you should know some of the you should know all of the first line agents, and you should know at least few of the second line agents for the exam purpose and for your daily purpose. So for the initiation of the antihypertensive agents, you should first know what are the first line agents like thiazide diuretic, calcium channel blockers, AC inhibitors, or ARBs are the first line agents. So when if the patient is in the stage 1 hypertension, you can start them on the single antihypertensive agent and titrate the dose according to the response. However, if the patient is in the stage 2 hypertension, then it is you can either use a single agent and titrate the dose upwards, or you can use the combination of the two first line agents and titrate according to the response of the patient. However, once the patient is started on the antihypertensive therapy, you should monitor the patient monthly in the initial phase of the starting of the treatment to assure that they have reached the target blood pressure and they are having compliance or the adherence to the drugs. And so there is a term known as hypertensive emergency, which is defined as the presence of the target organ damage due to the sudden increase in the blood pressure or the high blood pressure. Target organ damage includes like papilledema, presence of the renal failure, or any other kind of the organ damage. If there is organ damage, if the patient presents with very high blood pressure with organ damage in the emergency, then we should, in some cases, we might need to use the injectable drugs. So some of the injectable drugs which can be used in those scenarios include the nitroprusside, nicardipine, levetiracetam, enalaprilat, esmolol, and nitroglycerin. You should know at least the name of the few drugs, injectable drugs, which can be used in the hypertensive patients, because these are sometimes used in the OT setup when the patient is intubated in those conditions, or when in ICUs, or when after surgery we have to use the injectable drugs. So you should know at least the name of the few drugs like esmolol, which is commonly used, levetiracetam, nitroprusside, nitroglycerin. These are commonly used injectable drugs, and their choice depends upon the comorbidities of the patient. Like if the patient has hypertensive encephalopathy, nitroprusside, nicardipine, or the levetiracetam is preferred. Similarly, in aortic dissection, beta blockers like esmolol, levetiracetam are preferred. As well as in the preeclampsia or in the eclampsia of the pregnancy, usually you have to use either hydralazine, levetiracetam, or nicardipine. So you should know some injectable agents also. So now we'll be discussing about how to treat a hypertensive patient who present with other comorbidities, because the choice of the antihypertensive agent depends upon the comorbidities of the patient. So first of all, if the patient has stable ischemic heart disease, or any patient who presents with the previous history of coronary artery disease, coronary bypass surgery, ischemic heart disease, and in those patients, our goal is to reduce the blood pressure to less than 130/80. And so for that, we will first of all use the AC inhibitors, ARBs, or beta blockers. As I have mentioned previously, even though beta blockers are not the first line agents for the hypertension management, they come to be the first line agents when there is a coexisting ischemic heart disease. So beta blocker, AC inhibitors, and ARBs should be used to maintain the blood pressure less than 130/80. And if after using these three drugs, if the BP goal is not met, and if the patient has the features of angina, then we can use the calcium channel blockers as as well as we can use other types of diuretics like thiazide diuretics and the aldosterone antagonists to control the blood pressure. So basically from this slide, you should know that in patients with ischemic heart disease, beta blocker, AC inhibitors, and ARVs are the first line agents which should be used in these patients. And if some patient present with a heart failure, then again, our goal is to reduce the blood pressure by 130/80. In most of the patient with heart failure with reduced blood pressure, they will present with the hypotension. However, if patient is presenting with the arterial preserved ejection fraction, they can have higher blood pressure. So in those patients, uh, we can use initially we can use the diuretics to decrease the congestion, and then we can use one of the first line agents to treat the hypertension. Similarly, if the patient presents with the renal impairment, that is, if the patient has CKD, then again our goal is to decrease the blood pressure by 130 by 80 millimeters of the mercury. And so before treating the CKD patients with hypertension, we need to uh, check whether there is presence of albuminuria or not. If the patient has albuminuria, then we use ACE inhibitors. And if patient cannot tolerate the ACE inhibitors, then we can use ARBs. However, if patient has no albuminuria, we can use either of the first line agents as a first choice in the patients with the CKD. Similarly, after the kidney transplantation, we can treat the patient with the calcium channel blockers based on the patient's profile. And if the patient with a stroke presents with the elevated blood pressure, we should start them on the blood pressure medications only after the 72 hours of the ischemic stroke, because if we decrease the blood pressure in the initial 72 hours, we are more likely to do more damage than benefit, because in the initial 2 to 3 days, patient with the stroke has a chances of increasing of the weakness if we decrease the blood pressure fast. So we have to wait for 2 to 3 days before starting the blood pressure drugs. So if after 2 to 3 days of the stroke or the TIA, if the patient has the blood pressure of more than 140 by 80 millimeters of mercury, then we can use any one of the first line agents to decrease the blood pressure to less than 140 by 90. Similarly, if the patient is newly diagnosed case of the hypertension, then we should again use the same principle to start the treatment. However, if the stroke patient has the BP of less than 140 by 90, we should not start them on the treatment. Next important comorbidity in the hypertensive patient is diabetes. If the patient has diabetes and hypertension, then we can use any one of the first line agents. However, if the diabetes is associated with renal impairment or proteinuria, then we can use ACE inhibitors or ARBs depending upon the patient's glomerular filtration rate. Similarly, if some patient has valvular disease like aortic insufficiency, then we don't want to use the drugs like beta blocker, which will decrease the heart rate. So we have to use those drugs cautiously in patients with aortic insufficiency. Similarly, in the patients with the thoracic aortic disease, beta blockers are preferred, and in the pregnant females, so methyl-dopa, nifedipine, and levodopa are the preferred drugs. We cannot use ACE inhibitors or ARBs because of their teratogenic effect. So you should know the drugs which can be used in the pregnancy, because that is a very important MCQ in your exams. Methyl-dopa, nifedipine, levodopa, and hydrolazine, these can be used during the pregnancy. So if any patient is undergoing surgical procedure and if they have elevated blood pressure, we have to be careful. If the patient is very high, like if the systolic BP is more than 180 or the diastolic BP is also very high, then we should defer the surgery. However, if the patient are taking other drugs, we can consider stopping the drugs, or we can consider using the alternate drugs before performing the surgeries. So, however, we should be cautious while interrupting the hypertensive drugs, because they can cause the rebound hypertension or the rebound tachycardia, which can cause the various complications to the patient. So we should be very careful while adjusting or while increasing or decreasing the drug doses in the patients who are planned for surgical procedures. Similarly, this is the blood pressure threshold for the most of the patient. So as you can see in this chart, most of the BP goal in almost all categories of the patient, our BP goal should be less than 130 by 80 millimeters of the mercury. This is the blood pressure what we want to achieve by starting the patients on the antihypertensive agents. However, in you can decrease the cutoff based on the patient's comorbidities. Like if the patient has chronic kidney disease or diabetes mellitus, you can even keep the patient on the lower blood pressure. But it depends on the patient's profile, their preference, their ethnicity, as well as their other coexisting comorbidities. You have to be very careful about this. So there is one next type of hypertension, which is known as resistant hypertension. So you should know something about this type of hypertension also. So if a patient has a blood pressure of more than 130 by 80 millimeters of Hg, despite of taking 3 antihypertensive drugs, including at least 1 diuretic agent, or if the patient is taking more than 4 antihypertensive agents and still it is very difficult to control the blood pressure, then we call this kind of the patients as having resistant hypertension. So before we start, so for the resistant hypertension patients, we need to exclude the other pseudo causes of the pseudo resistance, like the whether the BP is measured accurately or not, whether the patient is obese, if there is physical inactivity, excessive alcohol consumption, whether he or she is not adhering to the non-pharmacological therapies or not. We should evaluate about that, and we should minimize, or we should discontinue other interfering substances or the drugs, over-the-counter drugs which increase the blood pressure, like over-the-counter use of NSAIDs, use of the nasal drops, decongestants, oral contraceptives, as well as the cocaine, amphetamines, or drug use. They can cause the increase in the blood pressure. So we should work up for all those things while evaluating the patient for the resistant hypertension. So once you evaluate all those things, you should also consider the secondary causes of the hypertension, because these secondary causes of the secondary hypertension is very difficult to treat, and that can be the reason for the resistant hypertension. So if you are suspecting secondary causes, you should look for the primary aldosteronism, you should look for the renal impairment, you should look for the evaluate for renal artery stenosis. Similarly, you should evaluate for pheochromocytoma and the obstructive sleep apnea. And after evaluating for all these conditions and making sure that patient has is compliant to the non-pharmacological as well as pharmacological therapy, and then we should start to escalate the antihypertensive therapy for the resistant hypertension. We can add second-line agents like diuretics, and basically we can use mineralocorticoid receptor antagonists like spironolactone or eplerenone. These are preferred agents for the resistant hypertension, as well as you can use other second-line agents depending upon the patient's profile. So if you are unable to control the blood pressure even after adding these second-line drugs, then those patients should be referred to the specialist or the cardiologist for the further management of the blood pressure and to identify the underlying cause for the resistant hypertension. So you should keep in mind that if you cannot control the blood pressure easily using 3 or more drugs, and if the patient is compliant, then you should always consider that there might be some secondary cause of hypertension, or the patient might be non-compliant to the non-pharmacological treatment. So you should consider all these things while managing a patient with the hypertension. So main most important thing is that drugs won't work if the patient don't take them properly. So you should make patient aware about their disease, the complication of the disease, the need of keeping the blood pressure in the control, and the long-term comorbidities which can influence the use of these drugs. So if you can counsel the patient about all these things, that will increase the adherence and understanding of their disease condition. So that will increase the compliance and adherence of the patient to the antihypertensive agents, because once you start patient on the antihypertensive treatment, they have to treat these drugs for lifelong. So most of the patients, or many young patients, will be reluctant while starting the medicine. So you should always counsel them about the benefits, risks, harms of the disease, as well as the use of the how can you decrease the adverse effect of the drug. You can counsel all patient about everything, so that there will be the increased adherence to the treatment. So basically, while treating the patient with hypertension and any other disease, you should simplify the regimen. You should impart the knowledge to the patient. You should modify the patient's beliefs and behaviors. Like some patients think that they will decrease the blood pressure by taking some bitter gourd, or they will take some Ayurvedic medicines with the hope that it will decrease the blood pressure. So you have to modify the patient's beliefs and behaviors, and you should also have the proper communication about the complications, about the drug adverse effects, as well as you should evaluate the adherence, and you should ask the patient to follow up regularly to make sure that patient are being benefited from the antihypertensive therapy. So this is for today.